Hello, welcome to the workshop, Chronic Graft-versus-Host Disease of the Mouth. My name is Lynn Spina, and I will be your moderator for this workshop. I'd like to thank Sanofi, whose support helped make this workshop possible. It is my pleasure to introduce today's speaker, Dr. Jacqueline Mays. Dr. Mays is an immunologist and a clinical trials dentist. She heads the Oral Immunobiology Unit within the Division of Intramural Research at the National Institute of Dental and Craniofacial Research, National Institutes of Health, the NIH. Her research focuses on how chronic graft-versus-host disease, GVHD, develops after a transplant using donor cells, an allogeneic transplant, the causes of salivary gland dysfunction after transplant, therapies to improve the treatment of oral GVHD with clinical trials directed toward advancing chronic GVHD therapy. Please join me in welcoming Dr. Mays.
Good afternoon. Thank you so much. It's a great privilege to be here, and I want to thank all of you who have logged in or who are watching the recording of this session. Hopefully I have some information that will be of use to you in getting back to a healthy mouth state. Wonderful. So today I am going to take this time to tell you a little bit about general oral care after transplant. I'll share some information about oral complications that are both expected and unexpected after transplant, things that can happen in your mouth, signs to recognize chronic graft-versus-host disease in the mouth, different types of oral graft-versus-host disease, and then, of course, we'll speak at length about how we treat those different types of oral chronic graft-versus-host disease. We'll start out talking about general oral care with a focus on the critical elements post-transplant. We'll talk about how to establish community dental care, the who, the what, and the when. We'll discuss the critical role of oral cancer screenings after your transplant. We'll review some non-graft-versus-host disease post-transplant complications, and then we'll talk about graft-versus-host disease in your mouth, what it looks like, what it feels like, and how we can treat it. So just to go over some nomenclature so that we're all clear on what I'm referencing during this webinar. Within a normal oral cavity, we call this sort of soft, wet tissue that you see everywhere mucosa. So when we're talking about oral mucosa, we're just generally talking about all of the skin inside your mouth. The oral cavity is sort of a very unique and rich environment because it is the gateway to your body. It's not protected and closed off the way your brain is, or separated the way your gastrointestinal system is. It really is constantly interfacing with the outside environment. It's where your food goes in. It's where you breathe the air for the first time. So because of that, your mouth has built up a lot of natural defenses and really has a rich immune system that is integrated within these mucosal tissues. As part of this, you have tonsil tissue sort of back at the back of the mouth. You've got a really robust immune system underneath the tongue. So this sublingual immune response, it's also very thin skin. So that's why oftentimes medications that need to be administered quickly will be popped under the tongue if they can't go through your venous system. And when I talk about the buccal mucosa, if that comes up, that is the cheek inside your cheeks, or the skin inside your cheeks. So you've got, two cheeks right and left, and there's buccal mucosa covering the inside lining of each of those. You've got 3 sets of major salivary glands. These produce most of that watery saliva that's in your mouth. There's a set of parotid glands sort of higher on your cheeks, and then underneath your chin, you've got the sublingual and submandibular glands. And then throughout the oral cavity, you've got about 2,000 to 3,000 minor salivary glands, which also contribute to the saliva production within your mouth. But more importantly, they also reflect what's going on in your major glands. So if we want to see within the tissues, those minor glands are where we will look rather than looking into your major glands. because it does reflect oftentimes the same immuno and pathological states that your major glands are undergoing. Okay, how do you take care of your mouth after your transplant? Really, it's the same way that you would take care of it before your transplant, but you might have to be more thoughtful about some of the elements of oral care and oral hygiene post-transplant, because you might find that your mouth is sensitive in ways that it wasn't sensitive prior to your transplant. So thinking about just brushing your teeth every day, we strongly encourage all of our patients to use toothpaste with fluoride. Fluoride, and I don't have a slide for this, but I'll talk about it briefly. Fluoride is a really critical molecule that's able to remineralize parts of your enamel that might have gotten soft or become destabilized, and it's able to re-strengthen that enamel. So if you have dry mouth, if you're maybe not having the world's best diet when you have mucositis after your transplant, fluoride can help to restore some of the damage that has happened with your tooth enamel and keep that strong. For patients who might have a sensitive mouth after transplant, a lot of times patients find that they are sensitive to flavors, both in their food and their oral care, things like toothpaste that they weren't sensitive to prior to transplant. Oftentimes using a fruit-flavored or a children's toothpaste can help bridge that time period when your mouth is particularly sensitive, so that you're not constantly struggling with minty toothpaste and not wanting to brush because your mouth is sensitive to that toothpaste. For sensitive teeth, we recommend fluoride rinses, which can be prescribed by your dentist, or gels that can be brushed on your teeth at nighttime, or using an over-the-counter desensitizing toothpaste. So some of these brands include Pronamel, Sensodyne, Colgate sensitive toothpaste. If you walk down the aisle at any drugstore, you can find a whole list of them. The caveat with these desensitizing toothpastes is that oftentimes you need to use them for several weeks to a month to really see a difference in the sensitivity of your teeth. So if it doesn't work the first time, keep using them and give them a chance to take effect. There are also professional desensitizing treatments that some dentists offer. There are several options within the dental office. These include fluoride that's brushed on the teeth, but also other things all the way up to some laser therapies that can be used to desensitize teeth. For patients, we often see with our chronic graft-versus-host disease that as your joint mobility becomes impaired with progressive sclerotic chronic graft-versus-host disease, oftentimes brushing, the mechanical act of brushing your teeth becomes challenging. So in those cases, I'm a big advocate of electric toothbrushes, really any kind from the drugstore that fits your hand well, that you feel like you can get in your mouth. Some people need a smaller brush head on their electric toothbrush so that they can sort of maneuver it around their mouth. So anything that works well, don't hesitate to give yourself the aid of using an electric toothbrush. Okay. Everybody's favorite topic, flossing your teeth. So this is just to get the schmutz out from between your teeth, any food particles that are there. Cavities love to grow within plaque that is left in between your teeth. And the whole idea behind flossing is to get the debris out from between your teeth. This is no less important after your transplant, but it becomes a really complex issue. Depending on your transplant center, a lot of transplant centers will recommend not flossing your teeth for a long period of time after transplant to prevent that damage. And I know you can't see this, but I'm pointing at the floss touching the gingiva in this picture, where you can get just a little bit of tissue damage and have bacteria go through into your circulation. So they want to prevent that exposure to bacteria in your mouth, so they tell you not to floss. Sometimes centers forget to tell you when you are allowed to floss. So once you've stabilized post-transplant in general, unless there's a specific medical reason, you should be okay to floss your teeth again. There are many ways to do this to clean between the teeth. There are a number of aids that have been developed. So even if you're not, using the long floss string, you can use some of these little pick devices. Some of them have a string of floss stretched between them, and some of them are really just like little tiny brushes that you can fit between your teeth. My personal favorite, as long as your teeth aren't too close together, are these water flossers. There are a number of different brands, but these will shoot a little stream of water at sort of a strong force rate between your teeth and knock out any debris that's there. So this takes away sort of that mechanical force of the string abrading your gingiva and is a very gentle way to clean between your teeth. A question that we often address, especially because our patients at the National Institutes of Health are often not local, so we are seeing them, for annual transplant follow-up, but we're not taking care of their regular dental care. So often I find myself in the situation of helping our patients find community dental care, aka a dentist that understands their graft-versus-host disease, their medical situation post-transplant, and can really be of assistance to them. So step one is simply to tell your dentist that you're a transplant survivor. If your dentist, gives you a blank look, they might need a little bit more education, or you might need a different dental office. Next is to show your dentist anything unusual or new that you see or feel in your mouth. What does this include? This includes mouth ulcers, lumps, and bumps. These things typically will heal within 3 weeks, and you can see that I've got stars on that slide because that 3-week time projection for healing, unfortunately, does not include chronic graft-versus-host disease. And then if you notice anything with your teeth, your gums, your lips, your tongue, and your cheeks that has changed, that is something that you should show your dentist. Do make sure that you're asking for oral cancer screenings. Usually your dentist will sort of feel underneath your chin and check your temporomandibular joints, and then use a piece of gauze to move your tongue around for that oral cancer screening process. They might not tell you that's what they're doing, but when you're in for your regular follow-ups, make sure that you're asking if they're doing that oral cancer screening. Next slide. So as I alluded to, not every dentist appreciates your complex medical history and needs. If your dentist is not a good fit, if you find that when you go back to your community dentist after transplant, they're not taking your concerns seriously, it's probably time to interview other dental offices. You can do this by asking, do you have experience treating medically complex patients? A good place to look for care are at university or medical center clinics. So the university clinics include dental school faculty or resident practices. These are people who have sort of the time, the education, and the patience to deal with more complex problems rather than simply drilling and filling teeth. Alternatively, if you need specialty care, oral surgeons are generally well-versed in graft-versus-host disease and other types of pathology, though they may not have the care. And if it's available to you, your best option, and I apologize for not putting this on the slide, is truly an oral medicine specialist. Oftentimes, these people are housed within a university or medical center faculty, and occasionally they also have private practice clinics. Critical for anyone who has been through bone marrow transplant is to get an annual oral cancer screening. We know that the highest risk for oral cancer in post-transplant patients is in patients who have had a history of chronic graft-versus-host disease. So that constant inflammation can increase the risk. I like to tell my patients that even though the risk is increased with a history of chronic graft-versus-host disease, the risk of oral cancer is still very, very small. So it's something that you should screen for or have screenings done for, but it's not something that you should stay awake at night worrying about. The most common time for us to identify these types of lesions are at 5 to 10 years post-transplant. The tongue, especially the lateral borders of the tongue, so the sides of the tongue that sort of touch your teeth when you're at rest, are the most common site to find these types of secondary or subsequent oral cancers. The picture here is from one of my patients who had noticed this lesion just 2 to 3 weeks prior to the photo. It had probably been there for a long time before that, but it didn't become painful until that point. And this turned out to be an oral squamous cell carcinoma and required fairly extensive treatment. So again, this is not something that you should stay awake at night worrying about, but it is something that requires regular screening. Thinking about things that can happen after transplant in your mouth. Most of you, I assume, on this seminar are past your first 100 days post-transplant, and you may recall mucositis, dry mouth, and oral thrush that may have occurred during that very early peri-transplant period. During the overlap period, we often think about drug-induced complications, so things that come from your systemic doses of methotrexate and sirolimus and other drugs being a bit off in their titration, or viral infections that can sometimes break through and cause lesions in the oral cavity, including herpes simplex virus and human papillomavirus. The later complications when we think about things that are happening post-transplant include obviously chronic graft-versus-host disease, and we will talk about that in detail a little bit later in this presentation, as well as these secondary oral cancers that we think about as happening in the 5 to 10 year or later post-transplant period. Many of you have likely experienced some of these non-GVHD post-transplant complications, including loss or change in taste. Oftentimes, this loss or change in taste will be tied to your pre-transplant chemotherapy regimens. Specific types of chemotherapy are notorious for causing taste changes. Oftentimes, our patients will report changes in their food preferences after transplant, so things like a difference in the way that like meat or steak tastes, or how they perceive the texture, or how tomato sauce tastes after transplant. And those are things that generally will resolve with time. You may have noticed some radiation-induced dry mouth if your pre-transplant regimen included total body irradiation, or if some of your cancer therapies included targeted radiation. You may have noticed medication-related oral ulcers or lesions that were not graft-versus-host disease, but did require treatment. Our patients, because you are immunosuppressed after your transplant, often fight off a number of different infections in the oral cavity that would normally sort of be there as part of the normal oral microenvironment, but are able to sort of overgrow and cause problems where they wouldn't normally in a non-transplant patient's mouth. And we often see cold sores, mostly coming from herpes simplex virus recrudescence or reactivation during the immunosuppressed period after transplant. So again, this is a virus that most of us have living in our bodies already that normally wouldn't cause a problem until you hit an immunosuppressed state. So what does HSV look like? The reactivation is common. It usually comes on very quickly and causes these little tiny oral ulcerations. I like to show this picture on the left because it's unusual to catch these blisters when they're still in blister form before the roof comes off of them, and they just look like little tiny ulcers, but they start as these little tiny blisters. And then they're unroofed, or they open up and leave behind usually very small sort of punctate ulcers. And these ulcers are exquisitely painful. So this is one way clinically that we begin to suspect that these are virus-induced ulcers. To diagnose this, we'll swab the ulcer and have the lab test for herpes simplex virus DNA and sometimes other types of viral DNA as well. And this is typically managed with lidobenalox, something that many of you are familiar with. It's this magic mouthwash that's a combination of Maalox, lidocaine, and Benadryl, along with systemic antivirals. Another common post-transplant complication that is not graft-versus-host disease is oral thrush or Candidiasis overgrowth. This can occur in pseudomembranous forms, like this white, sort of furry-looking tongue over on the left-hand side of the screen, or erythematous. So this is this bright red, sort of shiny-looking tongue in the middle. And there's just another photo of pseudomembranous candidiasis in the back of a throat on the right-hand side of the screen. So this occurs when candidiasis, which is a normal component of the flora in your mouth, is allowed to overgrow. Oftentimes this happens when patients are on either systemic or topical steroids, and this can include when you're on things like a steroid inhaler, so a fluticasone inhaler. Oftentimes if patients go on FAM therapy and you're having trouble rinsing your mouth out to get that steroid out after you use the inhalers, sometimes thrush can occur at that point. One of the classic clinical signs of candidiasis overgrowth in the oral cavity is burning, so sort of a burning feeling in the mouth, even if all you're doing is drinking water and that is burning. That's a sign that this might be a fungal-related infection. And typically this is managed with topical antifungals, so things like antifungal agents like clotrimazole that you'll put on your tongue and sort of let melt so that it can be addressed directly in the oral cavity, and it can be added to your systemic antifungal prophylaxis if you're still on a systemic antifungal agent. Okay, another non-graft-versus-host disease ulcer that we often see in the oral cavity in our post-transplant patients are these mTOR inhibitor or sirolimus-induced oral stomatitis. This occurs when excess circulating levels of mTOR inhibitors, such as sirolimus, it could be everolimus, it could be some of these other newer drugs. If the levels become off or a bit high systemically, this can induce painful aphthous-like ulcers. They have well demarcated borders and focal erythema, so really clear borders and a little bit of redness associated with them typically. The white arrows in each of these photos point to the ulcers. I know they're a little bit difficult to see because they look a bit more like erosions. They're not like those little punctate dots that you saw with herpes simplex virus. These can be small, they can be quite large, and usually they're managed in a pretty straightforward manner with topical steroids, with magic mouthwash, and with adjustment of the medication dose that was causing sort of this erosion of the oral mucosa. Okay. So we've gone through our list of things that are not graft-versus-host disease that we often see post-transplant. I want to talk about what it feels like when graft-versus-host disease starts within the oral cavity. A lot of our patients report that one of their first symptoms is dry mouth or temporary blisters on the roof of the mouth, and this can occur quite suddenly. Oftentimes, things have been just fine, and then patients find that their mouth is suddenly very dry, and it's so dry that it's waking them up at nighttime, and they need water to chew and swallow their food, which wasn't something that they needed to do before. These blisters on the roof of the mouth, and we have some photos of these coming up later in the slide set, these are called mucoceles, and they happen because you've got immune cells infiltrating into the tissue and squeezing the openings of your salivary glands closed. So the saliva has trouble getting out into your oral cavity. So when your salivary glands are trying to put that saliva out into your oral cavity, instead it's causing these little blisters on the roof of your mouth and sometimes on your lower lips. And those are called mucoceles. Red or white patches in your mouth that you cannot scrape off may come up. Oftentimes these aren't really the first signs, but they might be the first signs that patients notice because they're, looking in the mirror and you open your mouth and you see that there's a white patch or a red patch in an area that was never there before on the inside of your mouth. And that's something that, it's not extra food left over from breakfast. It's something that's actually part of your tissue, so you can't scrape it away. Mouth ulcers are things that patients will often feel first before they see them. So you might notice that, it's really painful when you're eating under your tongue and you look under your tongue and there may be an ulcer there at that point. This might be accompanied by these white lines on the cheek lining or other mucosal surfaces. So we call these, sort of their more official name is lichenoid striations or lichenoid patterning. This is one of the diagnostic signs for oral chronic graft-versus-host disease. If we see these within the oral tissues or within the oral cavity in an allo transplant patient, we know that this is most likely chronic graft-versus-host disease. But these can occur on the inside of the cheeks, on the gingiva. We sometimes will see them on the bottom side of the tongue or on the floor of the mouth or on the roof of the mouth also. So they can really occur anywhere within the oral cavity. And then along with dry mouth, one of the earliest symptoms that our patients report noticing is really this oral sensitivity. They might be eating one of their favorite foods and suddenly notice that, it's burning and it's painful. They might notice that if food even has a fleck of pepper on it, that it's too spicy, and they become very, very sensitive to these types of things. And this can include spicy foods, sort of that we think of as traditionally spicy, things like chicken wings or spicy sauces, citrus fruits, oranges, grapefruit, things like that, or even acidic foods like tomato sauce. Are some of the early foods that often trigger this type of oral sensitivity with onset of chronic graft-versus-host disease. So what does GVHD look like within the oral cavity? So I typically think of this as occurring in 3 separate domains. You've got the mucosal lesions that are very easy to see clinically and at home. This includes hyperkeratosis, so these are sort of these white and red lesions that we're talking about. This is the roof of the mouth over here on the left-hand side. There is another roof of the mouth directly under that on the hard palate, showing sort of these lichenoid lesions, these white patterning. And you can see that all of the openings to the minor salivary glands here on the roof of the mouth are a little bit red, so they're a bit red and irritated. If you go up toward the middle, you can appreciate that the gums of this patient are very affected by the graft-versus-host disease, so they're red. There's some hyperkeratosis on the bottom part of them. And then these pseudomembranous ulcerations oftentimes are quite large. These are on the inside of the cheeks on the buccal mucosa. The one in this lower middle photo. And oftentimes these ulcers really aren't painful if patients are not eating or drinking. It's very different than the virus-induced ulcers where oftentimes this will be exquisitely painful. Oftentimes these occur and patients might not even know that there are ulcers here. Mucoceles that we were talking about, these blisters on the roof of the mouth, are here on the palate, and they can also occur on the lower lip. And then you've got a tongue here showing this patchy tufted hyperkeratosis. The other 2 domains that we think of oral graft-versus-host disease as occurring in include perioral sclerosis or limited mouth opening. This can be because the temporomandibular joints are affected, or it can be because the skin around the mouth has become so sclerotic that the mouth opening is really limited. Within the salivary glands, we know that immune cells can infiltrate and start replacing the lovely acinar balloons that make your saliva within the salivary glands with collagen bundles. So this is when your mouth really becomes dry. And the salivary glands can be targeted by chronic graft-versus-host disease without having oral mucosal involvement. And our worry when you lose your saliva is that dry mouth can lead to smooth surface caries, so the kind of things that you would expect to see in younger children that might be drinking from a bottle. This baby bottle tooth decay can start occurring in adults with dry mouth. It occurs in Sjogren's syndrome, and we see it in graft-versus-host disease patients who have really impacted salivary glands. So this is just illustrating in our cohort, or our group of NIH patients who we've studied graft-versus-host disease in the oral cavity for a very long time, that you can have each one of these distinct domains, limited mouth opening, oral mucosal lesions, and salivary gland dysfunction without necessarily having the other associated problems in the oral cavity, which makes it really clear to us that different types of oral graft-versus-host disease may need different types of treatment. We know that the underlying pathology is different and that the prognosis is different. So to diagnose graft-versus-host disease in the oral cavity, if we see these lichen planus-like changes, we know that we can confidently diagnose GVHD. If we have at least one of the distinctive manifestations, dry mouth, mucoceles, mucosal atrophies, pseudomembranes, ulcerations, we like to try and confirm with a pertinent biopsy, especially so we can rule out other possible diagnoses, these oral infections, these drug reactions, or new cancers. And again, this is just looking a little bit more carefully at the diagnostic features of GVHD. These are different ways that the lichenoid lesions might look on your cheeks and on your lips. Within the palate, this is just showing different ways that the hyperkeratosis and the erythema or the redness might look on a palate, and it's showing a different photo illustrating what these mucoceles might look like. Oftentimes we see in our GVHD patients that their tongues will atrophy. So your normal papilla on your tongue that help you to taste might shrink up a little bit, and the tongue might become a little bit shiny. We call this atrophic glossitis. Sometimes there might be red and white patches on the tongue. And then again, this is that patchy tufted hyperkeratosis tongue that looks a lot like candidiasis, but is not candidiasis at all. Pseudomembranous ulcerations, unfortunately, can also occur anywhere. Oftentimes, they like to hide underneath the tongue. We will frequently see them in clinic on the buccal mucosa, so the inside of those cheeks. And then here is a patient that had those across the lower lip. So when we diagnose GVHD in the clinic, questions that we'll often ask patients: is your mouth suddenly drier? Is your mouth progressively drier? Can you chew and swallow food without drinking water? Are you taking any medications that cause dry mouth? We know that a lot of antidepressants especially can cause dry mouth by themselves, so adjusting that type of medication can improve dry mouth. Did you have a radiation as part of your cancer therapy or transplant preparation? Unfortunately, unlike for the oral mucosa, in order to clearly diagnose graft-versus-host disease in the salivary glands, a biopsy of the minor salivary glands is needed for that formal diagnosis. Preventative measures. And I say preventative measures, but I don't mean in any way, shape, or form to imply that if you have graft-versus-host disease, you could have prevented it with strict oral and dental hygiene. These are just things that can help things not become so severe. But after seeing thousands of graft-versus-host disease patients, I will confidently tell you that you cannot prevent GVHD with excellent oral hygiene. But the way to keep your mouth in the best shape possible is to brush your teeth, seek routine dental cleanings with endocarditis prophylaxis, so antibiotic prophylaxis if that's what your medical team recommends. And then to regularly surveil your mouth for infection and malignancy. So that can be something that your dentist is doing. It can also be something that you're simply doing when you're brushing your teeth. Just look at your mouth, see if anything looks a little bit different, and let your dentist or your physicians know if things do look different. Moving into therapies for changes in the mouth after transplant. Topical therapies for mucositis, which really happens in the early post-transplant period, include cryotherapy, so things that involve ice chips or other types of cold therapies. Oftentimes we'll use supersaturated calcium phosphate rinses for patients with mucositis. This tends to help support the wound healing process in the mouth. And obviously you need adequate pain control. Typically this is done with opioid analgesics. The first line of therapy for oral graft-versus-host disease in almost every case is dexamethasone oral suspension. In the United States, this is typically given at 0.1 mg per ml. We know from published data that 29 to 58% of patients will respond to this, and you might be looking at those numbers and saying, gosh, that's low. It's not particularly effective, but it is our best first line of therapy. Because the second line of treatment, the next thing that we go to for our patients is not particularly well established. I will mention that if you're on topical steroids to treat your graft-versus-host disease, the contact time for these medications is really critical. So you want to make sure that you're using it for the amount of time that is recommended. You don't have to switch these medications as if you're in a Listerine commercial. I tell my patients to set a timer, for the 2 to 5 minutes, whatever was recommended for your medication, and read your email or, check out your social media. And then when your timer goes off, to just spit the medication back into the sink. You want to just make sure that it has enough time to soak into your tissues within your mouth so that it can give you the good medication effect that it's supposed to. For mouth sores, lichen planus-like changes, these lichenoid lesions, we will often use progressively increasing strengths of steroid rinses, so starting with that dexamethasone rinse and then going up in both concentration and strength of agent. Occasionally, if patients are particularly steroid sensitive, we'll use calcineurin inhibitor rinses, so things like tacrolimus, in a topical oral rinse form. If there are oral ulcers that are isolated, so things that are occurring as sort of a single ulcer on your tongue or a single ulcer on the inside of your cheek, that's when we like to really focus and use a topical steroid gel, a tacrolimus gel, or to do intralesional injections of triamcinolone. So this is the same medication that a rheumatologist would use for painful joints, but we find that it's particularly effective if it's injected right at the ulcer bed until that ulcer is able to close. One of the important functions of the mucosa in your mouth is to provide that barrier function, right? So in order for your mucosa to be a great barrier, it needs to have all of the ulcers healed up to keep you protected. Okay, aids for dry mouth. This is a particularly important topic for individuals who have salivary glands that are impacted really by anything, whether it's radiation, chemotherapy, or host disease. Sugar-free gums or candies can be helpful for dry mouth, and I want to emphasize the sugar-free part. A lot of times these will contain an alcohol-based sugar called xylitol. It starts with an X. It's known to also reduce tooth decay, so it's a great thing if you're looking for your sugar-free gum to chew or your sugar-free candy to check the label and see if it contains xylitol. Lemon flavors in particular can stimulate saliva flow. Frequent sips of water, staying hydrated can be helpful. And then lubricating rinses, including biotin or any number of the other products that are out there, can be helpful. These are often very specific to individuals. So if you don't like one, try another. I was joking with a patient yesterday that we really needed a tasting bar in our clinic to see which dry mouth rinse was to their personal preference. There are prescriptions available for patients who are just not making enough saliva. These stimulate your cholinergic nervous system and increase the secretions that your body is making. Medications include pilocarpine or Salogen, or the more specific Cevimeline or Evozac is the trade name. These can take a few weeks to a month to show an effect. They only work if you have those acinar saliva-producing cells left within your salivary glands. And medically, they're not appropriate for everybody. So this is a conversation to have with your medical team. I'm beating a dead horse a bit, but fluoride is really important. Please check your toothpaste. Does it contain fluoride? This is critical for rebuilding dental enamel that has mild damage. Toothpastes that include active hydroxyapatite or zinc hydroxyapatite can also help to rebuild tooth enamel. So this is another great ingredient in modern toothpaste. Your saliva is really important for washing that food away from the teeth, buffering acids and bases in the mouth, and returning calcium to that damaged tooth enamel. Unfortunately, dry mouth comes from less saliva or equals less saliva, which equals less protection from decay. If you have reduced mouth opening, progressive gentle stretching can maintain or improve your mouth opening. Some aids to help include stacked tongue depressors, so opening your mouth, to a stack of, 6 or 7 tongue depressors and maybe adding one in every week or every month as you're able to open a little bit further. I strongly recommend that this be guided by a physical therapist or even an occupational therapist. They can develop a program of extraoral and intraoral massage to help break up fibrotic tissue and can be quite helpful in improving oral opening. So in severe cases, perioral steroid injections around sort of the edges of the mouth has been helpful for some of our patients with reduced oral opening. And in really severe cases, surgical intervention can help to open the mouth a little bit further. Key points: see your dentist regularly after your transplant has stabilized. Call your dentist if you notice any problem or change in your mouth, and take care of your mouth by brushing and flossing every day. A healthy mouth is less likely to develop problems, but as I said, it certainly cannot prevent every challenge. And now I guess we've reached the Q&A part, and I'm happy to take any questions.
Thank you, Dr. Mays, for your excellent presentation. I'll now begin the question and answer session. If you have a question for Dr. Mays, please use the chat box on the left side of the screen to submit your question. We will answer as many questions as possible. Our first question is, do you find pain in the teeth and sensitivity to be a common issue? I was told it was likely teeth clenching or grinding related and could be resolved by using a night guard and high fluoride toothpaste. It has resolved some, but not entirely. It's been about 4 months. Your thoughts, please?
4 months. You still have a ways to go. I would say that you've gotten excellent advice with the mouth guard and the fluoride gel. So those are very helpful things. We see a lot of times, especially in the early post-transplant period, that our patients will develop exquisite dental sensitivity, so their teeth will go through periods where they're really sensitive. We don't know exactly why, but we do know that it gets better. And it sounds like you're getting really good care. I don't have a specific recommendation, unfortunately, to help that get a lot better. But until your tooth sensitivity improves, I would take care to avoid anything that is triggering that tooth sensitivity and continue to use your night guard and your fluoride.
Thank you. Next question is, have you had much success with gum grafts in patients with oral GVHD who have had a lot of gum recession?
This is a great question, and this actually is reminding me of the sticky note on my desk because there's an issue that I wanted to bring up that was not part of these slides. So I'll answer your question first, and then I'll go back to my sticky note. So gum grafting can be complicated when you're still on systemic immunosuppression. One of the things that prednisone, sirolimus, tacrolimus, all of these drugs are doing is to reduce activity of your immune system. So we find oftentimes that patients, especially patients on prednisone, will have trouble if they have any sort of regenerative procedure done, like gum grafting, in healing. If you're on an mTOR inhibitor, I would not recommend gum grafting. So if you're on sirolimus, for example, because that directly impacts wound healing. If you are off of your systemic immunosuppression, we have seen good results in patients who are a little bit further out from transplant in being able to, sort of cover up those re-exposed root tissues. I will comment in general that gum grafting is really complicated, even when done by outstanding periodontists in perfectly healthy individuals. So it's got a sort of a limited success rate. And then going back to the issue that I wrote myself the note to talk about and then didn't, is really in implant placement, dental implant placement in our post-transplant patients. We have seen that when patients wait until they're off systemic immunosuppression, that dental implants can be quite successful. I will tell you that we don't place them in the clinic here at the National Institutes of Health. It's oftentimes when I'm seeing patients for their annual follow-up that they will, come in with a beautifully well-integrated dental implant, and we'll have a conversation about how that went. Implants are not always successful, but for patients who have lost teeth secondary to chemotherapy and protracted cancer treatments, when you're, really focused on making it through that part and not as focused on your dental health, and have ended up losing either several teeth or needing to have all of your teeth taken out and replaced, ideally with an implant-supported denture. We have seen that our patients have done quite well. So I wouldn't let the fact that you've had a transplant ever exclude you from the patients that are eligible to have teeth replaced with dental implants.
Thank you. Are there any foods that may aid in developing saliva?
Oh, that's a great question. So lemon flavors are helpful for stimulating saliva flow. And I will tell you that oftentimes when we're trying to collect saliva in the clinic for a patient for a research study, we'll paint their tongue with citric acid. Now, we don't do that in graft-versus-host disease patients because oftentimes that's very painful. So things that have lemon flavors or that little bit of zing that you recognize as citric acid can help with saliva flow. The mechanical act of chewing helps with saliva flow. So if your muscles can tolerate it, sugar-free gum can be quite helpful in stimulating saliva flow. And of course, drinking lots of water always helps because the more water you have in the body, the more saliva you can make.
Good advice. The next question is, can you discuss application of dexamethasone for oral GVHD? Is it helpful to gargle and should be followed by nystatin to diminish the possibility of fungal infection?
Oh, these are great questions. So I will tell you that we have a tremendous amount of experience using dexamethasone in graft-versus-host disease patients. As I mentioned, it's really the first line of therapy. So pretty much everybody on this call who has had graft-versus-host disease has probably also used topical dexamethasone as a swish and spit medication. The first part of your question was about gargling. I don't think it's necessary to gargle. I do think if you're holding it in your mouth, and this is just, mouth closed, liquid in, that will let the steroid have enough contact with your mucosal tissues. Steroids are lipophilic. They really like fats and oils and things like that, so they're really good at traversing through the oral mucosa. You just have to give them enough time to make it through. So that's why you want to keep that medication in your mouth for a prolonged period of time. Gargling will really not help that. The liquid, is thin enough that it can get to the back of your throat. If that's sort of the idea behind the gargling, is to get to sort of the beginning of that throat opening so that you can treat that tissue as well. There are medications that medical teams might prescribe as a swish and then a swallow, but that is a very different issue, and that's something that should be discussed really, really clearly with your medical team because then you're increasing sort of your systemic dose of steroids, which is something that needs to be carefully controlled. Did I miss a part of this question? We talked about the gargling. We talked about the dexamethasone application.
Right. I think good. Yeah.
Okay.
We're going to go on to the next question. Is a high-dose fluoride toothpaste as good as using fluoride gum molds?
Fluoride gum, what was the last part?
Molds. A mold.
Molds. I'm wondering, I bet this is fluoride trays. So sort of your dentist can make custom fluoride trays for you where they take an impression of your teeth and then they make something that looks like a little Invisalign tray that you can put fluoride gel in at nighttime and sort of sleep with that in so that your teeth get maximum exposure to that fluoride gel. So you will get more exposure and more sort of therapeutic benefit from a fluoride tray than you will from a prescription fluoride toothpaste. However, it depends on your individual situation if you really need that additional therapeutic exposure or not. If you just need the extra support, oftentimes the prescription toothpaste that has a higher concentration of fluoride in it than normal over-the-counter toothpaste will be sufficient. But if you really need intensive support, so for patients undergoing head and neck irradiation, for example, they really truly need those fluoride trays. And if patients are really suffering from dry mouth and have decay associated with that dry mouth, I will try and get them in fluoride trays so that they can, really intensively try and repair some of that dental damage or prevent some of that dental damage. So not quite the same, but depending on your individual situation, the prescription fluoride toothpaste can, be adequate treatment rather than a fluoride tray.
Okay, great. The next person asks, can decalcification of teeth and gum recession after transplant be prevented?
Yes, to an extent. This is a tricky question because you are asking both about gum recession and about tooth decay. So the tooth decay we know that we can prevent. We know that we can prevent it with good oral hygiene and a lot of times with fluoride supplementation so that, if a little bit of damage happens to the enamel, it can be remineralized and sort of reversed. The question about gum recession is a much different question, unfortunately, because this is soft tissue. And we know that when patients are on, for example, high doses of prednisone for a long period of time, we'll see a recession in their gingiva. So that's something that really can't be prevented, absent not being on those high doses of prednisone for a long time. But that's something that's needed systemically to treat graft-versus-host disease and other types of conditions. So as much as we would like to prevent gum recession, that's not always something that we can prevent. If it's gum recession that's coming from periodontal disease or gingivitis, those are things that are a little bit more preventable with regular cleanings, maybe seeing a periodontist every 3 months. But typically in our transplant patients, we see that the gum recession is more related to systemic medications.
Okay. Next question. Do you have any specific recommendations for frequency of teeth brushing and frequency of dental visits, specifically if you are dealing with GVHD?
Okay. So frequency of sort of oral hygiene, I would love it if everybody was able to brush their teeth after, each time they eat. So thinking about like three times a day kind of thing. Practically, if you can brush it in the morning and in the evening, that is wonderful. And then for frequency of community dental visits, I would like everyone to be there at least once a year so that you can get that oral cancer screening. We generally recommend a dental cleaning every 6 months. It's easier if you are able to catch problems when they're small, if you're able to catch a cavity when it's small, if you're able to catch a tooth that's a bit off kilter. Are much easier to fix and smaller problems. So those are sort of the general recommendations. Minimally see your dentist once a year. Hopefully it could be every 6 months. I have a number of patients who have a lot of dental challenges who will go every 3 months for a cleaning to help keep things, under control and at a good, healthy state.
Thank you. One question is, how do I get rid of mouth ulcers? I know you mentioned something in your presentation as it relates to treatment, but can somebody get rid of the mouth ulcers themselves?
Oh, this is a great question. So it depends on what the ulcers are from. If they are ulcers related to graft-versus-host disease, oftentimes a topical treatment will help. So topical dexamethasone or a steroid gel that will go directly onto the ulcers, whether it is like a triamcinolone gel or a clobetasol gel. Sometimes we'll put that on and maybe cover it with a piece of gauze for a period of time, like a 15-20 minute type period of time, not hours, so that the steroid can really get to the ulcer. If they are long-standing oral ulcers, sometimes there are more chronic type oral ulcerations in the mouth that really they don't even hurt anymore. They've just been there for so long that the tissue has sort of curled under and it's not not healing properly. So in those cases, those are the patients that we oftentimes will give steroid injections directly at the ulcer base to try and convince that ulcer to heal, so that the mucosal barrier function can be restored in those patients.
Right. The next question relates to the use of some GVHD drugs that are recently approved. So if you see oral GVHD resolve with the use of Rezurock or Jacqueline, is it gone? Or do you watch for possible flare-ups?
We always watch for possible flare-ups. So we have seen really great results with Rezurock, with this ROCK2 inhibitor. In clinical trials, we've seen oral graft-versus-host disease improve quite a bit in many of our patients. The caveat to that is that it's still a new drug. We haven't seen a lot of patients with chronic graft-versus-host disease when they start this. We've only seen a handful of them. So what I'm telling you is very anecdotal. But with graft-versus-host disease, there's always that question, right, of if it's completely burned out, or if it's going to flare up again. And a lot of times with the oral cavity, we see, that we just keep treating the flares until they stop happening. So I unfortunately can't give you any amazing hope about this being, the one drug that will snuff out the GVHD in the oral cavity for good.
Okay, and this will have to be our last question. We're running out of time. So this person writes, I've had my transplant 5 years ago and now have GVHD and a numb tongue. What causes this? What can I do to treat it? Is it common?
So a numb tongue is not common, but you're not the first patient that I've met who has a numb tongue with graft-versus-host disease. Depending on exactly what the numbness is, if it's like a numb sensation or if it is simply altered, trouble tasting anything, and that's making the tongue feel numb, that's a tricky question. I don't have sort of a great stock answer. If the tongue numbness is secondary to graft-versus-host disease, GVHD treatments will help it. It's possible that it's more of a neurologic manifestation of the graft-versus-host disease or of other conditions. I would recommend potentially seeing either an orofacial pain specialist. They are people who would be able to maybe guide you through some less common treatments for that numb tongue. It's quite the
yeah.
But that might be a place to seek additional treatment.
Okay, great. Good advice. I'd like to tell everybody out there who is dealing with GVHD that we do, BMT Infonet does have a directory of GVHD specialists. It's on our website, bmtinfonet.org, and you go to the tab that says Find Treatment, and you will see dentists in there that are versed at treating GVHD, another place to start. So with that, on behalf of BMT Infonet and our partners, I'd like to thank Dr. Mays for a very helpful presentation, and thank you, the audience, for your excellent questions. Please contact BMT Infonet if we can help you in any way, and enjoy the rest of the symposium.